Welcome to the award-winning AUA Leadership in Business Podcast, an official podcast of the American Urological Association. This episode is brought to you by AUA's Public Policy and Advocacy team and addresses the powerful role urology played in driving the recent FDA removal of the black box warning for estrogen therapies, a significant victory for AUA and its members who have long advocated for this change.
Hi, everybody. We are so happy to be here. I'm Dr. Rachel Rubin, and today we are doing a big debrief. We are talking about the huge win for women's health. The FDA has officially removed the black box warning on estrogen products, including that of vaginal estrogen products. So every urologist in the world is taking a nice deep breath with pride because we're going to save them some extra minutes in their day. And I am joined by the most wonderful human in the world. Why don't you introduce yourself?
Hello, I'm Una Lee. I'm a urologist, urogynecologist in Seattle, Washington. And I have gotten to partner with the fabulous Dr. Rachel Rubin on several things, but one of our big wins was the AUA guidelines on GSM and this push to remove the black box warning off the estrogen products. So this is a momentous time and a big win for women's health and urology, and honestly, all specialties that help women, which is everyone.
We're just thrilled to be here and to debrief, right? We've been through, we have experienced the last few weeks, this push to have this happen. We all knew this was maybe coming, might be coming. And so it's a really big win. And we wanted to kind of share our thoughts on this and have just a short conversation with you. So we're going to start with sort of why was there a box in the first place? Like, what is the history of the box? And I'll go a little bit. It is in 2000, the Women's Health Initiative came out, and it was this study, this $1 billion NIH study that looked at PremPro, oral, synthetic estradiol, progestin pills for menopausal symptoms. The average age was 62, and they gave these birth control pill style medicines to women, and they followed them for many years. And they stopped the study early and said, oh my God, it causes stroke, blood clots, heart attacks, probable dementia, breast cancer. None of that was true. They didn't really analyze the study, but they did a big press conference. And after that press conference, they just put this blanket warning on all estrogen products, which included all vaginal estrogen products, which, as we know, have nothing to do with oral PremPro. And so there was no advisory committee at the time. There was no expert panel at the time. They just put this label on. And for 20 years, this label stood there. And so, Dr. Lee, why do you think no one, really there were a few attempts at getting this box label off, but for 20 years, nothing was done about it?
Well, there's a lot there to unbox and unwind, but I think over the years, the scientific data has gotten stronger, right? There's been longer term studies, big, huge studies on the overall safety of estrogen, systemic and local vaginal. Again, two different things, but both contributing to women's symptoms and quality of life. So the data has gotten stronger. The analysis and understanding of that WH study has gotten better, right? There's been a relook at the data and a re-understanding of it. It was a study designed to look at prevention of disease. They thought that estrogen could prevent disease in older women. And so it was a study designed for one thing, and then the results were interpreted, in that moment and applied to younger women who were, and not for the benefits, right? It was a study on risk and it wasn't a study on benefits. So now we have lots of studies on the benefits. And again, we can talk about this, but I think the black box, if you've ever seen it, it's actually, it's pretty alarming, right? It's the first thing on the page. It's the first thing that patients see when they see the insert. And it was a huge barrier. We're going to talk about that. But your question was, why now? So the data has gotten stronger. And honestly, I think the guidelines contributed because it concisely and comprehensively put together the data. And then the logical next step was to have the FDA push the FDA to remove it because it was such a strong and a compelling argument.
And so this is a huge deal, right? And it affects our clinical practice every single day. It affects your clinical practice every single day. You have been doing this work. You see predominantly women. You see
Yep.
predominantly women in your practice. And so I would argue, do you have this conversation 30 times a day, 40 times a day? Like what is, and how has that evolved over the years in terms of your ability to explain this? And you've actually made it one of your research topics because it is such a challenging conversation.
Yeah. Well, I think we all see this, right? Like as urologist or as primary care or gynecologist or all these specialties, we see women with symptoms, whether it's overactive bladder, whether it's a urinary tract infection, whether it's a recurrent urinary tract infection, whether it's pain, dyspareunia, um, prolapse, incontinence. We see all these symptoms, and actually one of the underlying diagnoses that's come out of the last, decade and longer is the genitourinary syndrome of menopause. To acknowledge that low estrogen in the tissues is contributing to, these symptoms. And so let's say, as a urologist, as a pelvic floor surgeon, I'm seeing people and I'm differentiating, oh, is this prolapse that's causing your discomfort or is this GSM? Oh, I think it's GSM based on the level of your prolapse and what you're telling me. So you prescribe something and explain and do your very best to get them to, understand and use it. 3 months later, they come back. If they've used it, they're like, I'm fabulous. This is great. This like resolved my issues. 3 months later, they come back and they're like, oh no, I read the insert and I just got scared and I didn't take it. And so then it's like, you're back to square one to try to explain this. So after doing it so many times and after so many years, it just realized the importance of doing something like this to make a change and to help women.
Absolutely. And I mean, I think, this idea that, I think about anticholinergics, right? I think about oxybutynin, that actually we know long-term use can cause dementia, and yet vaginal estrogen, which should be, first-line therapy for OAB, as before something like an anticholinergic, doesn't cause dementia, has never been shown to cause dementia, and yet the box labeling says that it causes dementia. And so again, urologists have really, shied away from vaginal hormones, thinking, oh, that's not my lane. Gynecologists are going to do that. This is not urology. And for the AUA to put these guidelines together and say very definitively, this is our lane, this is urology, this is absolutely, and then to go even farther to advocate at the FDA at the highest level and get the warning labels changed is truly remarkable. So, getting to go testify before the FDA, I say this because it was not in, we have been talking about this topic, not just myself, but so many of us have been talking about this nonstop for years and years and years. And it's simple. It's not sexy. It's not robotics. It's not, it's not a shiny object. It doesn't come with a lot of RVUs. And yet we have been over and over talking about the benefits of vaginal hormones in the treatment of GSM and the prevention of urinary tract infections. And so when we got this invite to the FDA, in my wildest dreams, right? So the GSM guidelines were my moonshot. That was my most biggest accomplishment I could ever imagine in my life when it happened. And within the year, we were invited to present that data to the FDA. And then we were invited on stage with, the head of HHS and the head of the FDA to really discuss the importance of these topics. And so urology was front and center to say this costs our government tons of money. This really kills our patients. It affects their quality of life. This is so important, and urologists really could be very proud about this. So really, with
what was it like, Rachel? What was it like to
What was it
testify?
like?
I know you were, yeah, tell us about that experience. Give us
my
the
friends,
inside scoop.
I can give you lots of insider information. I was not expecting in a moment to be talking to the second lady and to be talking to the celebrity Cheryl Hines, who's RFK's wife, and I was talking to the head of ARPA-H. I mean, it was just wild, the level of conversations, and everybody was hungry for this information and to really understand that these are just regular people who have family members who suffer with urinary tract infections, who have GSM. These were the level of conversations that I was having. And truly, it was not on my bingo card in 2025 to do any of these things. But, I said to myself, I said, when they asked me to do it, I certainly didn't want to, but I said, if I can control my message, I can control the few minutes that I get. We were able to record Dr. McCary's podcast, myself and Kelly Casperson. So 2 urologists were invited, to go record the FDA podcast, which is really just, again, showing how urologists are at the forefront of this advocacy, which really is so excellent. But truly, the GSM guidelines are what propelled us forward majorly in this fight. And so, what we love, Dr. Lee, how does this align with what the multidisciplinary work that we invested heavily in the GSM guidelines? So for anyone who doesn't know, Dr. Una Lee and Dr. Melissa Kaufman, they chaired the guideline committee. And if you haven't read it, it is elegant, it is short, it is sweet, it is just an absolutely beautiful document. So talk about that process and how, working with all these different specialties really helped catapult us forward.
Yeah, I would say the AUA guidelines are one of the shining stars of our organization. And in 2021, I think, Rachel, we talked about this at AUA maybe the year before that, and we said, let's propose this guideline to the AUA. And we proposed it, and with a lot of support and collaboration, it was accepted to be a guideline. And it's been years in the making. And that's the kind of, and it was truly multidisciplinary and a true collaboration. There was multiple organizations who supported it and had representation, multiple specialties.
Patient representation.
Yes, and patients and internal medicine and the Menopause Society, urogynecologist. And so, again, a true collaboration. And we had fun. We debated a lot. We really dug into the data and came up with something that was practical and also getting into the hard areas. Really the big elephant in the room is this associated with cancer, right? That's what women are scared about. And women will suffer and withstand a lot of things because they want to live for their families and for what's important to them. And even if there's they heard there was cancer involved, they will not use something or do something. And so I think hormones got tainted with the word cancer or whatever, for this historical reason. And so the GSM guidelines really dug into that. And you've seen the data, Rachel, and we've presented this together. The data is so strong and so compelling for the safety of vaginal estrogen. It is not associated with the development of cancer, recurrence of cancer. You can have a personal history of cancer. And so that's what I think the strength of the guideline is to have really put that evidence together and have it strong. We, as clinicians, as doctors, have to feel confident in the safety of this and the patients feel that. You can say all the words, but they're looking for how you feel about it. And that communicates to them. So I feel very confident and that it's safe. And then they're going to feel that. And when I talk to them about it. And so after doing all the guidelines work and publishing it in May of 2025, the next logical step was to push, the FDA for this to remove that black box warning. And Rachel was doing a lot of behind the scenes work on that aspect too. And then one of my, small contributions was to study GSM and the patient perspective. And that black box and the fear of side effects and the fear of cancer was a huge barrier. It really prevented women from using it and thinking about it. And it was misinformed, right? This black box contained misinformed, outdated information that fed that fear.
And so the lessons, right? We've learned the behind the scenes keeps coming up. So what people didn't see, right?
Mm-hmm.
Dr. Lee and I were furiously emailing or private tweeting everyone on the guidelines committee to beg and to advocate for them to do a guideline. So when they met, they had in their ears, us annoying urologists saying, please, 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 can we do this? We worked really hard to secure funding for the GSM guidelines and were able to get a grant, thanks to some really crafty, amazing people at the AUA. There was so much collaboration and behind the scenes work done during the guideline Guidelines Committee to achieve consensus and to get everybody's sort of voices heard. It really was a beautiful group effort. And then the work that it took to do advocacy, where you have to get signatures, where you talk to your representatives, where you work with everybody you can think of, you go on social media, you get loud. And then even when the FDA is interested, you still have to build consensus. You still have to get people involved. And so every piece of this, there's been behind the scenes work. But I think the most important thing is this is only the beginning, right? The guidelines were step one. People, it doesn't matter. Actually, it was Dr. Lee's guideline on recurrent UTIs in 2019.
It wasn't my guideline.
Okay,
It
but
was
you
the
were on
biggest-
that. Were you on the guideline?
I was, of course.
You were
but
on the
I'm just
guideline.
saying, it was
Okay.
obviously collaborative.
A very group effort. But in your guideline in 2019 on recurrent UTIs, it said use vaginal estrogen, but nobody did, right? I just saw it. I saw nobody was doing it to the level that was so important. So it's a lesson that you can't just write guidelines. You must shout it from every rooftop you can find. And so really what needs to happen now is the implementation of getting all urologists, all primary care doctors, all gynecologists to get out their pens and write the damn prescriptions. So if I ask you what myths still need busting, how can we get doctors and nurse practitioners and clinicians of every kind to write prescriptions? What are the next steps?
Yeah. So again, people have to feel like it's safe, right? People have to understand that it is not associated with cancer. The scientific data would not support that. And clinicians have to feel that and understand that and be confident in that. And that needs to be translated to patients, and not just urologists, but like you said, primary care, gynecology, oncology, all these different specialties. And so understanding the non-association with cancer and other side effects, and educating people that what the benefits can be, right? The benefits are going to outweigh, the potential other issues. The benefits, Rachel, what do you see? Give me an example.
Benefit. That's what's so funny.
Right?
It's all, there are no other drugs that have this much benefit. And this is Viagra, but prevents UTIs. Like it's Viagra, but better. So it's actually female Viagra. It helps with arousal, orgasm, lubrication. It makes sex not painful. It's the best sex drug in the world, right? It also helps with overactive bladder, urgent incontinence, and urinary frequency, and prevents UTIs. So it's the best urinary drug in the world. It also helps with itching, burning, irritation of the vulva and the vagina. So there are no, the benefits are enormous. And so how you sell this is so important. Like who wouldn't want to try that? And so the downside, the risks, honestly, sometimes people don't like putting creams in their vaginas. Okay, so you switch to a tablet or a suppository. Occasionally a woman will get a yeast infection. You treat it, you keep going. Like those are the worst case scenarios I see with vaginal estrogen. This is not a scary medicine. This is the safest medicine that we have in our arsenal. And so you must sort of love these medicines as much as you love tamsulosin, or I don't know, what other urology, Viagra, right? This is, if you're writing Viagra prescriptions, you must be just as excited, because I lectured to the sexual medicine meeting a couple months ago of where are your penile implants going to go, right? We are taking care of men's sexual health. We must be taking care of the partners as well. And we have the guidelines, which teaches you how to do it now. And it's not enough for you to say, oh, go to your gynecologist. This is urology 101.
Yeah. So we talked about side effects and fear of cancer. We talked about the benefits. Cost has gone down significantly, right? It used to be a barrier.
Used to be astronomical.
And now every year it's gotten better. There are ways that people can get it that's affordable. And again, that was actually one of my other studies, like, is it a financial burden? And I think in the past it has been, now less so, but it's also a mindset. Because I had someone last week who I said, they're like, oh, it's expensive. I don't know. I stopped taking it. I go, tell me how much it's costing you. And they said $60 a month. And I said, that's an amazing price, right? Like, yeah, you could maybe get it a little cheaper, but think about the benefits that you're getting for $60 a month. What else, and then you have to almost say, like, it used to be hundreds of dollars, right? And this is, again, to put it in the framework of the benefits, their cost, out of pocket, things like that. So,
And this is where the advocacy comes in as well. Like, we worked with Mark Cuban
mhm.
on private messages on Twitter, and they were able to get the cream, the vaginal estradiol cream on Mark Cuban's Cost Plus Drugs for $13 a tube. That tube is going to last you 2.5 months. You get it shipped to your house for $5 shipping fee. You can get multiple tubes. I mean, you're talking for $7 a month, you can use vaginal estrogen. Now, if you like the inserts, usually those are covered by your insurance, but the cash price can be a little bit more expensive for those. So we have to work hard with CMS, right? If we worked with FDA, now we get Dr. Oz on the phone and talk about how we can make sure that Medicare can really cover this robustly, because we published, right, that we could save Medicare between $6 and $22 billion a year with reduced UTI visits, infection, sepsis visits, things like that. So, so what's next? Like what I would like to see, I would like to see the urology community go all in on GSM. For my
Mhm.
oncology colleagues, I'd love to study this even more on bladder cancer patients, your BCG patients, your kidney stone patients. I'd love to see us look at this for our transplant patients, right? Because our transplant patients have so much risk of immunocompromise, and we must be studying them with vaginal hormones. I think there's so much opportunity to invest in research on this topic and actually really see incredible outcomes. What would you like to see, Dr. Lee?
I would like to see outreach to patients, patient education, clinician education, because I think the awareness is starting and the awareness within urology is there. I just looked at the 2024 census data, and 50% of urologists are familiar with GSM and prescribe. That's 50% that don't then, right? And so we've got some ways to go. Of the 50% that are prescribing, it's general urologist, women urologist, and non-academic urologist. So we've got another segment of urology to reach and have them embrace it. They will have, again, so many gratified and satisfied patients. So patient education, clinician education, outreach, awareness. There's more to go. You're right, but this is still a momentous shift, you know, change, landmark, historical accomplishment.
The important point is to tell your patient that that box labeling was never supposed to be on there to start with. It was never grounded in science or data, and we have gotten to the highest levels of government to prove it, and they removed the warnings. And this is really momentous, and hopefully they'll actually be removed in the next couple of months, but we still have to fight to make sure that we cross the finish line there. But I couldn't agree more, right? We have to educate loudly, because we all care about a woman in menopause. Every single person is close to someone, in menopause, whether it's your patient or your family member. I spoke at length when I talked to the FDA in July about my personal story about how the box label saying it causes stroke, blood clots, heart attacks, and probable dementia really hurt my mother in the hospital. She was in the ICU for 6 months, and she was immunocompromised after a bad transplant. And I couldn't get, she had a catheter. She was on ECMO. I couldn't get her home dose of Vagifem, right? But I knew she could die of urosepsis at any moment. I said, just this was her home dose. Like, it's not going to hurt her. And the doctors looked at me like we were working on the guidelines at the time. And the doctors in the transplant team, they all looked at me like I was crazy. And then we kept fighting. They said, no, it causes blood clots. I said, no, it doesn't cause blood clots.
Mhm.
Oh, well, it says stroke, blood clots, heart attacks. No, this is different. But the box kept, the labeling kept, chiming into everyone's ear. The pharmacy wouldn't dispense it because of the label. They said, no, this is going to hurt this woman. And then once the tube of estrace came up to her room, because I wrote the prescription myself,
Mhm.
right? There
Mhm.
was no applicator. The nurses didn't know how to use it, how to do it. And so every step of the way, this box made it very difficult. And if I can't get it through, right, me who is probably one of the louder persons in the world on the topic, What does everybody else do? And so you have to work with your institutions to make sure those warnings go away from your EPIC prescribing. From the pharmacist, we have to get the word out to the pharmacist that this is safe. In fact, your beautiful guidelines, number 11, is the most elegantly written guideline statement I've ever seen, which says if you're on systemic hormone therapy, you should still be screening your patients and giving them treatment for GSM. Because if I give a patient an estrogen patch and a vaginal hormone therapy, the pharmacist says, oh no, you can't have both of these things. Of course she can, and that is very guideline driven data. And so we have a lot of work to do, my friends. Thank you for talking with us. I know we could talk about this all day long.
We could.
It is a huge step forward for women's health and for clinicians, and just urologists should be very, very proud.
Yeah. I will say one more thing. Yes, it is symbolic. I mean, practically, it is the removal of the black box, and it is going to help millions of women. But symbolically, it's also that women matter, right? And that women's health matters. And I think that's the sort of the big shift here, that this is the moment that everyone agreed. There was no disagreement on this. And every person, so many people contributed to this. This was a huge, huge effort, and we should all be proud as the urologic community, because I know a lot of people contributed.
Oh, I couldn't agree more. So my friends, for more resources, including the AUA guidelines on GSM, please visit auanet.org, and please have a beautiful day.
Make AUA Leadership in Business your go-to podcast. Subscribe today by searching Leadership in Business on your favorite podcast app and enhance your leadership and business education needs. Until next time, continue to learn, lead, and excel.